Okay, sorry folks, we have technical problems. It's, I guess, to be expected. So all I mentioned was our demonstrations against the rising price of insulin, which we've conducted in 2 cities, in Massachusetts and Indiana, and being on the board of MEDICARE, which is the organization that is working to advance single payer on the state level. Okay. So The Guardian has kicked us off with an article last week pointing out how the coronavirus pandemic has thrown the problems with our health system into sharp relief, as Jennifer was saying. There are some anecdotes that I will start with to give you some example of how that looks. Here's an article reporting on a 17-year-old boy in LA County, this is from last month, who presented to a walk-in and urgent care center with symptoms of COVID-19. But because he didn't have health insurance, he was denied care at that center, told to get to his nearest public hospital. He died en route to that public hospital. Now, we have no way of knowing if he could have been saved had he been seen at that initial site, and we'll never know. But that's just one of the many tragedies that's unfolding under our eyes. Here's a report of a woman who has a lymphoma, was concerned that she was coming down with symptoms of coronavirus infection. She presents to an emergency room twice. She's not admitted, but gets billed for $35,000. It's been pointed out here by Woolhandler and Himmelstein a couple of weeks ago that this unemployment surge that we're seeing because of the pandemic, so we have over 1.5 million newly unemployed people who are losing their health coverage because it's linked to their employment. And if the projections of the Federal Reserve are accurate, we can expect another at least over 7 million workers in the near future to be losing their employer-based health insurance because they lose their jobs. Again, The Guardian, Wendell Potter, writing in The Guardian, pointed this out, that up to 30% of people, at least in the immediate term, may be losing their jobs as this pandemic progresses, pointing out how, as he puts it, irrational and irresponsible it is for so many to be dependent on employers for health insurance, because that means you're just a layoff away from being uninsured. And I want to point out that Wendell Potter is a very important voice in this discussion. He was a former executive vice president of Cigna, one of the big for-profit insurance corporations. He jumped ship because he couldn't take it anymore, and he wrote this book called Deadly Spin. An insurance company insider speaks out on how corporate PR is killing healthcare and deceiving Americans. Highly recommended. It's still in print. Wendell Potter. So we can look at other countries around the world, other similarly well-off countries, and say how many people in other countries might lose their access to healthcare because they get fired. And the answer is 0, except for us at the bottom. 160 million people with employer-based health insurance are at exactly that risk. Now, even if you have insurance and you're unfortunate enough to get to catch coronavirus infection and be admitted with COVID-19, your out-of-pocket cost, it is estimated, could be at least $1,300 cash out of pocket, even if you have insurance, if you're admitted for pneumonia with COVID-19. So, again, Wendell Potter has pointed out that here's some of the kind of rattling loose pieces in our system. So last month, our president said that insurers, quote, had agreed to waive all co-payments for coronavirus treatments. Well, within hours, America's health insurance plans corrected him, and they said, oh, no, that's not the case. All they would be waived, this is at this point last month, would be cost sharing for testing. So here's a man who goes to the emergency room with insurance, knowing that the cost of testing is going to be covered. But guess what? That's just the cost of the test and not the cost of the emergency room visit, which has its own charges, which are not covered by that pledge to cover the cost of testing. His test was free, but his visit to the ER to get it was, quote, eligible for cost sharing, which meant he got a bill for about $2,000, even though the cost of the test was covered. So, again, our friend Wendell Potter points out that even in the midst of this surging pandemic, health insurers are still raking in record profits, varying from 6% for Cigna up to 15% for Humana. How is this possible? Well, it's a toxic combination of skimping on coverage for COVID-19 treatments and raising next year's premiums. So one calculation from California predicts that our premiums, those of us who are paying premiums for private health insurance, are going to spike from 4 to 40% next year as the insurers make back what they may be losing now. On top of this, it turns out that many emergency room physicians are managed by private equity-backed companies who have just slashed benefits for those emergency room physicians that we keep seeing on our TV as the heroes of this pandemic, and the nurses and the doctors and the health workers, including the cleaning staff, are surely our heroes in this pandemic, and they are now having their benefits slashed by the companies that manage them. Some of these ER physicians, and up to a third of ER physicians, are managed by these private equity firms these days. That's how crazy our system is. Well, Public Citizen pointed out some time ago that had we had Medicare for all when the coronavirus hit us, we would have been in much better shape. Why? Because for one thing, we know that people who know they have copays, who have to pay cash out of pocket to get care, even with their insurance, may avoid care and stay away. There's a lot of data on this question. I'm going to show you some of that in a few minutes. If we had Medicare for all and people knew they were covered, they wouldn't have to avoid care for fear of being bankrupted. Secondly, fragmentation in the payer landscape means slower and less coordinated responses. And for some international comparison, for example, we can look at South Korea. Now, it's not just that South Korea has national health insurance that allowed them to get control of the epidemic, although now they're experiencing a second wave. But as one of their professors of preventive medicine in Seoul pointed out, unhampered government intervention into the healthcare sector is an advantage when the virus is spreading fast across the country. We don't have that advantage here in the United States. Marcia Angel, whose name some people may recognize because she was for some years the editor of the New England Journal of Medicine, pointed out in this recent article from last month that the coronavirus pandemic is the best argument for Medicare for all. Why? Because if we're relying on the commercial market to provide us with test kits, that's not going to work, and it didn't work. In her words, we've converted healthcare into a market commodity. We've hollowed out our public health system. Now, if there's a silver lining to any of this, it may be that people are getting it. It is throwing into relief that we need major work on our healthcare system to get where we need to be. So this is a recent poll from Morning Consult, and it turns out that 43% of respondents of all registered voters, that's of any party, agreed with the fact that the coronavirus outbreak has made me more likely to support universal health care. 43% of respondents said, yeah, I get it. That's maybe the only good news, or it's one of the few pieces of silver lining to this massive cloud that's descended all over the planet. So let's talk about our healthcare system. The U.S. healthcare paradox, by far and away, we have the highest costs of any developed nation in the world. We get the highest rate of uninsured and underinsured people and the poorest performance. Let's look at each one of those factors. So here you can see per capita health spending. We're the green bar at the top, spending over $10,300 per capita per year. That's twice what the average of comparable countries is. And if you look at Canada down here, Canada's spending $4,752 per capita per year, less than half what we're spending. I want you to try to remember that. Remember the picture of this graph and where Canada is relative to us. And this is getting worse, not better. The divergence between what we're spending over time, which is the green line, and what comparably rich countries are spending over time in the blue bar is getting greater. That disparity is increasing. Okay, under uninsurance, the most recent data we have from the Census Bureau says that in 2018, 8.5% of the total population, representing 27.5 million people, had no health insurance at any point during the entire year. So that's a conservative number, and that's worse than it was a year ago. Does it matter that people don't have health insurance? It sounds like a stupid question, but we like to have data to look at, to inform us about these kinds of questions, even if the answers seem obvious. And here's a paper by Woolhandler and Himmelstein that tried to look at this question of controlling for other factors, just having health insurance, does that add a risk? And it turns out it does. In their data, in their analysis, simply not having health insurance, holding other factors constant in the analysis, accounted for a 16% increase in mortality for uninsured people. 16% increase in mortality just for not having insurance. So performance. Every few years, the Commonwealth Fund puts out a report called Mirror, Mirror, in which they compare the outcome, they compare, performance of health systems through a series of, a number of separate variables. I think there's 75 in their measurement. Their conclusion was that the United States healthcare system spends far more than other high-income countries, but the US ranks last on performance overall. Here's one example of such a measure. Here's life expectancy in years on the y-axis compared to health spending per capita on the x-axis. So you can see there's a relationship amongst all these countries. Some are high income and some are not, but we are the outlier. We should be way up here in our longevity, and we're not, considering how much we're spending. Something unique is going on here in our system. Okay, Medicare for All. This is just an assortment of headlines from the New York Times that I grabbed over the last 10 years and increasingly over the last few. The term Medicare for All was first coined by Ted Kennedy in 2005, and it was reborn, so to speak, during Bernie Sanders' presidential campaign of 2016. Sanders' pollster, a guy named Ben Tolchin, learned from his focus groups and polling that the term Medicare was widely understood to be a government-sponsored insurance program, and it was generally held in favorable regard by the general population. People had a good feeling about Medicare and knew it was a government health insurance program. So they decided on using Medicare for All to describe what the Sanders camp was proposing. Now, this is kind of a two-edged sword, because Medicare for All doesn't mean expanding the Medicare program as it is now to admit people of all ages and not just individuals over age 65. It means a different thing. What you call it means different things to the general public. So, for example, this Kaiser study showed that if you asked people their feelings about universal health coverage or Medicare for All, 63% responded, yes, that's favorable. But if you said, what about single payer health insurance, it drops down to 49%. But Medicare for All, as we're talking about it, is synonymous with single payer. So there's an educational disconnect here that needs to be addressed seriously if we're going to move forward with a grassroots movement, which is what it's going to take to get us there. So as I say, when we refer to Medicare for All, we do not mean the Medicare program as it currently exists. We could call it MEDICARE-AS-IS for everybody. We don't mean that. And that's why I prefer to say improved Medicare for All to make the point. Why is that? There's problems with Medicare as it is. And, you know, being on the Medicare program now, I have some personal authority to speak to this, but, you know, these facts are out there. Number one, it is not comprehensive. Part B of Medicare, which covers clinician costs like physicians, surgeons, therapists, et cetera, only covers 80%. So if you're going to protect your savings, you need to cover that additional 20%, or you could get wiped out if you have a cancer diagnosis and need multiple surgeries, for example. That makes it complicated. You have to decide, how am I going to cover that extra 20%? It makes it expensive because it takes cash out of pocket. And by the way, the Medicare program itself charges a premium. It's deducted from your Social Security payment. And finally, it allows in the for-profit insurers, the giant for-profit insurance companies, through the Medicare Advantage option. Now, I had 40 years experience as a physician, counting my years in training, and I couldn't figure it out. So fortunately for us in Massachusetts, the state provides counselors. They're called Shine counselors in every senior center in cities and towns across the state to help us make these choices when we go on to Medicare. And I was given I was given these handouts by the counselor that I saw. So here are my two basic options. I can choose a traditional Medicare with a supplemental plan, which is called a Medigap policy, and then I can buy drug coverage through Medicare Part D, or I can go with, again, Medicare Advantage, which is managed in general by enormous for-profit insurance corporations. There are some nonprofits in this space, including Tufts. Here's my Medigap chart showing me what some of my different options are. Here are the Medigap carriers that are available to me that I'm going to have to, if I choose a Medigap plan, I have these, I think, 1, 2, 3, 4, 5, 6, 7, 8 choices. They're all different. They all have different prices, different rules. They change every year often. Here are the prescription drug plans that I'm eligible to sign up for. There are 13 of them. They're all different. They all have different rules, different prices, different copays, change every year. The Medicare Advantage plans are similarly complicated to choose amongst. I wound up turning to my counselor and saying, tell me what to do and I'll do it. And that's what I did. It turns out, and we have data to look at, it turns out that seniors like me, and again, I'm a physician, so I'm a special case, but in general, seniors can't make informed decisions about this kind of detail. We have studies that show us, just faced with choosing one HMO over another, virtually 90% in this study of seniors did not have adequate knowledge to make an informed choice. Medicare helpfully sent me this email. I took a screenshot of it informing me this is what it's going to cost me for original Medicare with my supplemental Medigap policy and a drug plan. I can plan on spending $6,300 cash out of pocket for my Medicare coverage in a year. That's if I'm healthy. That's if I need nothing else but my routine preventive care and I don't get sick and I don't get admitted to the hospital, which would incur more charges, again, because there are deductibles, et cetera. If I went with Medicare Advantage, it'd be a little cheaper, $5,300 a year. So it's no surprise that this Commonwealth study found that amongst seniors on Medicare, almost 1/4, citing costs, didn't go to the doctor when they were sick, didn't fill a prescription or skipped a dose, didn't get a recommended test or Medicare treatment. These are all people on Medicare. They're afraid to get treated, to get care, because it costs them too much out of pocket. That's one of the huge problems with Medicare as is. Okay, let's pan back and look at the whole population. This graph represents how everybody in the United States is covered or not. So we have 49%, almost a half, of all individuals in the United States relying on employer-based private health insurance, okay? That's half of the population, essentially. We have 20% on Medicaid, 14% on Medicare, about 9% still uninsured, 6% on non-group exchanges, about half of which are 3% are Affordable Care Act exchanges. We'll talk about that, and 1% in the military. Okay, what are the problems with private health insurance? I say go single payer and essentially sideline private health insurance. Why do I say that? Number one, administrative complexity of having multiple private insurers with multiple plans that change all the time adds expense to the entire system. This is very well documented, despite the fact that here we have the CEO of Healthy Profits Incorporated saying, are you crazy? A government healthcare system would be a bureaucratic nightmare. Take a look. So this is an example of what we're talking about. The orange area here represents the growth in administrators, because when you have all of these different health plans changing all the time from all of these different private health companies, you need person power to administer, to do the billing, to do the arguing with the insurance company. Compared that to the blue down here, which is the growth in physicians. And private health insurance costs are constantly going up. This is one shot of that. Over the last 10 years, private health insurance costs have gone up over 50%. Compare that to Medicare and Medicaid. They can't control their costs. If we look at what it costs, what we're spending on administration, just on administration, okay? Just on billing and insurance-related costs, we're spending 34.2%. Over 1/3 of our health expenditure is going towards those administrative expenses, compared to Canada, up here, the dark blue bar, 17%. Canada is spending half of what we're spending just on administration of our needlessly complicated system. Another way of looking at these facts is that in the difference in healthcare spending between us and what Canada spends, fully half of it is accounted for solely by bureaucracy, solely by bureaucracy. Half the difference what we're spending and what Canada is spending. Here's some other data points to look at. The annual costs to physician practices to interact with insurers, and this has gotten worse over the last 10 years since this was published, $83,000. The average physician practice just interacting with the insurers compared to 20,000 in Canada. The number of hours spent by nurses in a physician practice, 20 hours a week interacting with insurers compared to 2.5 hours a week in Canada. And I am eternally grateful to Bloomberg Business Week for running this article, because whatever else you think about Bloomberg Business Week, it is not some left-wing news source, okay? It's not. The reason healthcare is so expensive, insurance companies, says Bloomberg. The arrangement that accounts for much of the difference between health spending in the US and other places is the enormous administrative overhead costs that come from lodging healthcare reimbursement in the hands of insurance companies that have no incentive to perform their role as payment intermediaries efficiently. Okay, my second problem, high out-of-pocket costs and their consequences for patients if you have private insurance. Here's a snapshot. The average family plan now costs a total of over $20,000. Again, on average, most of that is paid for by employers. We're talking about employer-based health insurance here, but over $6,000 is paid by the average worker. And you can see how that has grown over the last 10 years. The average worker is now paying $6,000 out of pocket for their employer-based insurance. The deductibles, that's what you pay on after you've paid your premiums and you have insurance. The deductible is what you pay before insurance starts to pay anything. And deductibles are rising steeply. They've quadrupled for a single plan. Over the last 10 years, they're up to $1,350 for single coverage. Now, almost half, 45% of people who are under 65 and in an employer-based plan are in a high deductible plan, okay? 45%. If you're in a high deductible family plan, your deductible has now risen to $4,527. That's what your family plan is going to demand that you pay cash out of pocket before they start paying anything. You're out that money. And remember, the Federal Reserve tells us that about 40% of people in the United States can't afford an unplanned $400 expense. So you can see what these deductibles are going to do to people. And this is one of the ways that the health insurance industry, so to speak, is dealing with rising costs. They are jacking up those deductibles. You can see it here in this Kaiser graph. Over the last 10 years, deductibles have gone up 162%. It's the deductibles where they're squeezing the patient. So it's no surprise that GoFundMe's major category of seeking donations is healthcare, accounting for 1/3 of all funds that are raised on GoFundMe's website. Private health insurance makes underinsurance the norm. What do I mean by that? Almost a quarter of people as of through 2018 are insured but underinsured. And again, these are people under age 65. These are people with employer-based health insurance. Being underinsured means that you're spending 10% or more of your net income on your medical expenses. Even though you're insured, you're spending, a quarter of people are spending 10% or more of their of their net income on out-of-pocket costs, despite the fact that they have insurance. Half of health insurance is for profit. Why is that a problem? Well, number one, profits get extracted from the healthcare dollar, and these health insurance companies are great at doing that, even in the face of the stock market crash and the global financial crisis of 2008. The following year, health insurance companies increased their profits by 56% in the face of the global economic crisis. Bernie Sanders made the claim, and Kaiser Health News checked it, that the health insurance companies are taking over $100 billion in profit in 2018. The fact check said, that's right. Sanders is correct. Total profits the companies posted, $100.96 billion, and that's probably an underestimate. Remember, this is money that's not going to patient care. It's not even going to administration, it's going to profits. So some of the reason for that is these spectacularly high salaries. Is this really where we want to be spending our health insurance dollar? Does anyone on the planet do anything that deserves a payday of $66 million? I don't think these guys do. When you introduce profit into healthcare, problems arise. So for-profit hospitals, it's been documented, for example, here, are more expensive by 19%. In the example of kidney dialysis, it's especially important because there's a direct relationship between the number of hours that a patient spends on the dialysis machine. More hours means less profit, but better health for the patient. So what do you think happens when those two things are in conflict with each other, as they are if you introduce profit? The answer is that people die more, that for-profit dialysis clinics' death rates are 9% higher than not-for-profit. It's no surprise, because the way I would summarize it is you can't serve two masters. Either your master is maximizing profits for the shareholders or doing whatever is best in the interest of the patient. You cannot serve those two masters. They will be in conflict. You have to choose one. Now, the public is already there on this. Only 16% of U.S. consumers in this recent Harris poll believe that health insurers put patients over profits. Finally, there's churn. You love your health insurance, you can keep it. Well, not really. The annual labor turnover for 2018 was 44%. That means some kind of change in job status for 44% of the workforce. If you were born between the late 50s and early 60s, the average person held almost 12 jobs in their early adult years. And in one study in Michigan, 28% of people with employer-based health insurance changed plans. So keeping that health insurance that you love is not an option for so many people who are getting employer-based health insurance straight up. Okay, so let's talk about what could be different. Improved Medicare for all, as I say, not Medicare-as-is, improved Medicare for all is synonymous with single-payer national health insurance. What is that? It means that there's one person paying the bills, not multiple insurance companies, not different programs, one single payer, and that's the government. It might be the national government, it might be the state government, it might be a coalition of state governments. There are different ways to configure this, but there is one government payer for the patient. Secondly, that most plans include global budgeting. This is how Canada does it. So hospitals, nursing homes, and other institutions are given a budget to operate with in advance of the fiscal year. They don't have to keep track every time they put an angiocath in a patient's arm. They don't have to keep an accounting of that and then fight with the insurance company for how much they're going to get compensated. They're given a budget up front, and hospital administration decides how to apply that budget. There is a free choice of doctors, clinicians, and hospitals to single payer. Very important. Uniform fee schedules, predictable for individual clinicians and other providers, price controls for drug companies, because you've got the entire government negotiating with drug companies. We now pay the highest prices in the world, and it's because none of that negotiating happens as it does in virtually every other country, at least every other developed country. So we could take some points from Canada. We don't have to go adopt everything about the Canadian system, but we can learn from it. This cartoon appeared during the Clinton administration when the Clintons were coming up with their managed competition plan, which didn't get enacted. Gosh, Bill, if only there were a fair, efficient way to give everyone quality, affordable health care. Well, you could have looked at Canada, you didn't. So Canada's cost control experience is shown on this graph, and before they adopted their national health insurance program nationally, they had the same kind of rising costs that we did, as you see on the left-hand part of the graph. And since then, you can see the divergence. Canada has done a much better job of controlling costs than we have. Now, when you say Canada, what a lot of people will come back with is, oh yeah, but you have to wait for everything in Canada. It's not healthy. You have to wait. Well, this has been studied, including by Canadians themselves, but others. As it happens, if Canadians triage by urgency of need, If you present to a Canadian hospital and you're having a heart attack or a stroke or you get a cancer diagnosis, you get care right away. The data show that that's as fast or faster than someone with good insurance in the United States. And the Canadians keep track of this. And they know they have a problem with elective procedures. They establish the Canadian Ministry of Health establishes its benchmark, and it knows that it's not hitting it for these elective procedures. Hip replacement, for example, 75% not hitting the benchmark. Knee replacement, not hitting the benchmark. Radiation therapy it's doing better than the benchmark in terms of wait times. So what do Canadians think about this? Multiple surveys of the Canadian population show that the system still remains a source of deep national pride and shared identity despite the wait times. One former hospital CEO in Canada put it this way: Canada makes you wait because everyone's included. But every nation rations its healthcare. One system is explicit in its rationing, Canada, where we howl at our wait times, and the other is implicit, because Americans can only get it if they can afford it, if they have the right kind of insurance. We can look at outcomes. There are a number of studies to look at that tell us how do patients fare with serious illness in Canada versus the United States. Well, if you're a type 1 diabetic and you're dependent on insulin to stay alive and you age off your parents' health plan, as shown on the right-hand panel here, so this represents the number of young American diabetics losing their insurance as they come off their parents' health insurance. And look over on the left here, this represents the number of people, or the rate at which type 1 diabetics are admitted to the hospital in diabetic ketoacidosis or diabetic coma. In other words, they weren't able to successfully manage their disease at home with insulin. The red line is Canada, the blue line is us. So you can see how much more likely it is that type 1 diabetics in the United States with our system are failing to maintain their health care to such an extent that they wind up in the emergency room in diabetic ketoacidosis and coma. We can look at cystic fibrosis. It's another good disease to compare because it's a genetic disorder, largely in the Caucasian population, so it presents similarly and has exactly the same complications in Canada as in the United States. This study showed that the median survival of patients with cystic fibrosis in the United States, 36.8 years. In Canada, 48.5 years. So here's a disease that's the same, that's highly responsive, that's very responsive to vigorous medical management. In Canada, those people are living 1/3 longer lives than in the United States. That tells us something about Canada versus the United States. We have review articles that have looked at this evidence. Here's one that showed that through its evidence review that if you're low-income Canadians, you have a 36% greater chance of getting better health care in Canada than in the US. For the general population, you have a 9% better chance of getting better health care in Canada than in the US. That if you're in the US, you are more likely to experience long waits for breast or colon cancer care, or dying while you wait for an organ transplant, more likely in the United States than in Canada. The relative risk is over 2, so that's not small. You're in better shape waiting for these procedures in Canada than you are in the US. That without reform, 50 million US patients will be treated less optimally and die earlier than had they enjoyed a single-payer health system like Canada's. That's from this review article. Okay, so this comes down to, really, I think we need to go right at it. Abolishing the private health insurance industry. I had these bumper stickers made up because that's really the question. And I think framing the question that way makes it clear that that's what we're talking about. That's what we have to talk about. I put the term in industry in quotes here because industries produce things. In my opinion, others' opinion, the health insurance industry produces nothing but profits for its owners and misery for everybody else. And I was pleased to see that this is exactly how the question did get posed in the first Democratic primary debate, which some of you may have watched. I think it was last June. There were 20 candidates at that time over 2 nights on TV. When they got asked the question, it was phrased just the right way. Raise your hand if you support abolishing private health insurance in favor of a single government-run plan. 4 hands went up. Bill de Blasio, mayor of New York, who dropped out soon thereafter, Elizabeth Warren, who's sticking to it. She has a plan that'll get there in stepwise fashion, but she's still supporting it. Bernie Sanders, who hasn't backed down, and Kamala Harris, who afterwards walked back her comments and said that she misunderstood what the question was. So there are bills right now in the national legislature. The House bill for improved Medicare for all, and you can see it says it right on the bill, to establish an improved Medicare for all national health insurance program is H.R. 1384. Its primary sponsor, excuse me, is Pramila Jayapal, who represents the Seattle area in Washington State. It was originally introduced in 2003 by John Dingell, at which time it was H.R. 676. You'll still see references to that in some of the older articles. It has co-sponsors, but only half of House Democrats, not all House Democrats, only half, no Republicans. In the Massachusetts delegation, it includes these 6 of our representatives, but Representatives Lynch, Moulton, and Neal are not signed on as co-sponsors. So if people are looking for something to do, and you happen to, especially if you happen to be in the in one of these representatives' districts, you might consider giving their offices a call and telling them how you feel about this. H.R. 1384. H.R. 1384, the Improved Medicare for All bill, would establish a national health insurance program administered by Health and Human Services. Covers all U.S. residents, not just citizens. Free choice of doctor, clinician, hospital. Automatic enrollment on birth or entering the U.S. Covers all medically necessary items and procedures, including dental, vision, and long-term care. Prohibits cost sharing, no out-of-pocket expenses. Again, that's critically important. Private health insurers could only offer insurance that is supplemental to, not duplicative of, the basic coverage of the national plan. So for example, you could buy insurance to say cover a private hospital room if you should get admitted to the hospital, or perhaps cover cosmetic surgery, which wouldn't be, except for reconstructive surgery, wouldn't be covered in the national plan in a 2-year phase-in. The Senate bill, primary sponsor is Bernie Sanders, as we know, but only 1/3 of Senate Democrats are signed on to co-sponsor S1129. It was originally introduced, it was S1804. That does include co-sponsorship by both of our Massachusetts senators, Ed Markey and Elizabeth Warren. Now, there are state-level proposals, as I mentioned, and including in Massachusetts. The plan in the state Senate is bill number 683, primarily sponsored by Jamie Eldridge. In the House, it's bill number 1194, sponsored by Linda D. Sabadosa and Denise Garlick. There are similar, state-level initiatives going on in many states, including prominently New York State and California. There's a big problem with the state-level efforts, not that we shouldn't pursue them, but realistically, we need to get buy-in from Washington, D.C. in order to make any of this possible. That was one of the problems with the Vermont plan. There wasn't full-on buy-in from Washington because you have to combine all of the federal funds into your state plan. So there is a bill right now that's been introduced by Representative Ro Khanna from California called the State-Based Universal Healthcare Act of 2019. That is a bill that would make it much easier for the federal government to collaborate with the states if any of the states want to try to establish single payer on the state level. But it currently only has 21 co-sponsors and only includes 2 from Massachusetts, Representatives McGovern and Presley. But people should be aware that something like this is going to be necessary if the states are ever able, if any single state is able to establish single payer within its own state boundaries. Now, the good news is the public is already with us, and different polls have different findings. This is one of the most optimistic. It's the Reuters Ipsos poll from June, July 2018. 70% of all respondents said yes, they support Medicare for all, including over half, almost 52% of Republicans in this poll. Now, that's not the finding of every poll. So, for example, exit polling during the Super Tuesday balloting of last month found amongst Democratic voters there was a spread of support for a government plan instead of private insurance that was at the low end of Massachusetts at 50%, ranging to a high end of 73%, for voters, Democratic voters in Vermont. Kaiser tracks on this, the Kaiser Family Foundation. In their most recent poll from the end of last month, March, found 54% favoring a single national health plan, sometimes called Medicare for All, in which Americans would get their insurance from a single government plan. They found 54% of the total sample in support, still a majority, and it's very consistent in their polling. In this poll, only 25% of Republicans, but still, that's a quarter of Republicans responding in this poll, said, yes, I support that. As I say, this has been relatively constant over Kaiser's polling. It's bumped up to 54% in April. And look at the opposition, by the way. The opposition is always substantially less over the last 3 years of Kaiser polling in terms of support for a national Medicare for All, I would say improved Medicare for All plan. But the public still doesn't get big chunks of this. So in this survey, again by Kaiser, when they asked people under a national health plan, sometimes called Medicare for All, would people continue to pay deductibles and co-pays when they use healthcare services? 61% of respondents said yes, they still expected to pay co-pays. And the answer is no. Improved Medicare for All means no out-of-pocket expenses at the point of care. So presumably, it would be even more popular if people really understood this. So we have a big chore ahead of us to educate the public about what this means, what we're talking about. Physicians are already there. In this Merritt Hawkins survey of over 1,000 physicians from August of 2017, 56 supported either strongly or somewhat single-payer health care, improved Medicare for All. And very importantly, just this past January, so 4 months ago, the American College of Physicians recommends transitioning to universal coverage system, their first choice being a single-payer financing system. They would also settle for publicly financed but highly regulated private insurance similar to the German system, which we're not going to talk about unless it comes up in the questions. But this is very important. The American College of Physicians, which represents physicians, internal medicine specialists, is the second largest body of organized medicine in the United States, and it's calling for single payer. The American Medical Association, on the other hand, had initially joined this group called the Partnership for America's Healthcare Future. This is the counterattack. Big pharma, some health insurers, and for-profit hospitals teamed up to launch the counterattack, Partnership for America's Healthcare Future. They call themselves, you may have already seen their ads on TV. Initially, it included the American Medical Association, PhRMA, the Pharmaceutical Manufacturers Organization, the Federation of American Hospitals, which is for-profit hospitals, and some Blue Cross Blue Shield insurers. The AMA has since dropped out because pressure from within its ranks, objections from AMA members, a significant number of them, forced the AMA to step out of this coalition. This coalition has already spent $143 million lobbying against improved Medicare for All just in the year of 2018. What is their argument? What does the counterattack want us to believe about improved Medicare for All? First, and this you hear again and again, improved Medicare for All, they say, would eliminate private health insurance and, quote, people love their private health insurance. Okay, is that true? Are there any data? Well, there are certainly anecdotes. Even Nancy Pelosi said this. A lot of people love having their employer-based insurance. It's everywhere. Well, was that true? Here's an anecdote that's worth reading. This young woman wrote this piece in the New York Times. Does anyone really love their private health insurance? Last fall. She's alive today not because of health insurance, but despite them. She's a type 1 diabetic. When she got kicked off her parents' plan because she aged out, she signed on to a high deductible plan under the Affordable Care Act, spending hundreds of dollars for each visit and insulin refill. And her insulin refills have been delayed countless times, not because of medical reasons, but because of arbitrary insurance limits and requirements to continuously document her condition. These are the kind of tricks that private health insurance plays, again, to increase their bottom line at the expense of patient care. But again, so this is an anecdote. We have some data to look at. The Commonwealth Fund did a survey where they asked people, adults under the age of 65, under the Medicare age, are you very satisfied or somewhat satisfied with your insurance? So if we could say that the very satisfied is kind of the equivalent of I love my insurance, look at what the employer-based, look at where the employer-based results are. 48% of people with employer-based coverage were very satisfied, or let's say they love their health insurance. Less than half of people with employer-based private health insurance said, I love my health insurance. And we don't know how many of these people ever tried to use their health insurance. My guess is that the great majority have not, and if they did, my bet is that 48% would shrink. But what I want to point out is, right next door, people on Medicaid, a larger share of people on Medicaid, which is government insurance, said they were very satisfied or they loved their health insurance. So from this study, we can say with confidence that people are more likely to love their health insurance, more than half, if they have public health insurance, less than half if they have private health insurance. Now, it's also been pointed out that many people might be confusing losing private health insurance with losing access to their doctor, their nurse practitioner, their clinician, or hospital of choice. So this survey tested that hypothesis. If you look at the top, under all voters, they asked the question, do you support Medicare for all? Again, they're not saying improve, but okay. 53% said, yeah, I support Medicare for all. Then they said, what if Medicare for all cuts the role of private health insurers? It drops to 46%. Then they say, what if the Medicare for all system cut the role of private health insurance, but let you keep your doctor and hospital? Look at that. It bounces back up to 55%, even higher approval. So that supports the hypothesis that the reason that people say they want to keep their private health insurance is they really want to keep their clinician in their hospital of choice. And that's not linked to their to health insurance under improved Medicare for all. Okay, the second argument against improved Medicare for all, it deprives people of choice. I personally love this one. Let me tell you why. First of all, it's a talking point. Our friend Wendell Potter said that when he was with Cigna Insurance, they were told by their own messaging consultants that when we promoted the purported benefits of the status quo, we should harp on the concept of choice because it polls well in focus groups. People just generally like this idea of choice. But what does it mean in health insurance? Well, if we were to believe Paul Ryan, when he was the majority leader of the then Republican House, here's how he put it. This was during the repeal and replace saga. Here's the key, said Paul Ryan. You buy what you want to buy. Free market health care, patient's choice, patient-centered health system. You choose the plan that meets your needs. You buy what you want to buy, not what the government tells you to buy. I suppose if you were landing from another planet and you had no concept of healthcare, you'd look at that and say, no, it sounds reasonable. Buy what you want to buy. But really, is it reasonable? First of all, we have data. Let's look at it. Most people can't figure it out. Austin Fracht, who's at Boston University School of Public Health, helpfully put this together in a New York Times op-ed. 71% of people can identify cost-sharing features of health insurance plans. Even with the details in front of them, only 11% could report what the cost of a hospital stay would be. And less than a third, 30%, could correctly answer questions about their own coverage of their own insurance. People don't get it, is what the data show us. But there's an argument beyond that, and it's this. Do we need choice in health insurance? I would say absolutely not, because we all need the same thing. What is that? I can summarize it in 8 words. Ready access to comprehensive care without financial barriers, or even better, ready access to comprehensive care with no out-of-pocket costs. I want you to think about it for a minute. What does that mean, choosing? Does it mean, it means gambling. It means I want the right to gamble that I'll buy a less expensive plan because I think I'm not going to have a problem in the next year. That's what it means. It means taking a chance. It means being able to gamble. But think about it. While each one of us is going to have different needs going forward in life, some of us may have very few, some of us may have very great needs. None of us knows if we're going to get hit by a bus tomorrow or get a cancer diagnosis next week. And if we do, We need comprehensive coverage for it. We all need the same thing. We're not going to use all the same things, but we all need that same kind of coverage just in case, because it's going to happen. Different things happen to different people. We need to be covered for all of it. We need the same thing. We need comprehensive coverage. Okay. Revokes hard-won union benefits, we're told. This especially came up around the Nevada primaries, if people noticed that. Well, here's what some union workers say. I'm a union worker and I want Medicare for all. Why? Because if we had Medicare for all, points out this union worker, we could demand much more at the bargaining table. In other words, if so much of their energies at the bargaining table weren't consumed by trying to get the best possible health plan for their members, they could focus on something else, like maybe pay and working conditions. Here's another union advocate who points out that Medicare for all would provide better coverage than any employment-based plan in existence today, because those plans rely on out-of-pocket payments, as I've said, and what's called narrow networks, where you can only go to certain clinicians, and all of that is better under improved Medicare for all. Okay, it is said it will eliminate administrative jobs, and that's true. It is true that all of those people that have to be hired to deal with this insanely complicated and unnecessarily complicated system, it will cost jobs. Elizabeth Rosenthal wrote this piece in the New York Times, and here's another recommendation. Elizabeth Rosenthal is a former emergency room physician who turned into a reporter for the New York Times. She's written a book called An American Sickness, highly recommended. She pointed out that, yes, Medicare for all could kill 2 million jobs, and that's okay. Why is it okay? Because the point of a healthcare system is to treat patients, not to buttress the economy. Let me point out, if that sounds heartless, that there are funds allocated and set aside in both the House and the Senate bills in the national legislature, the improved Medicare for all bills, to offer retraining and job placement services to those administrative staff people who are going to lose their jobs when we get, hopefully, a streamlined, single-payer, improved Medicare for all system. Okay, they say, the opponents say it eliminates skin in the game. That, in other words, if you're paying out of pocket for some of your care, you'll be a better healthcare shopper. Well, this one completely flies in the face of the evidence, and we have a lot of evidence. Here's a sampling of some of it. It turns out that if you charge people out-of-pocket costs, they stay away from care across the board. It doesn't matter. Preventive care, office visits, mental health, emergency department. When people have to spend money, they stay away from care because so many of them can't afford it. They're petrified of what it's going to cost them, even if they have insurance, for all kinds of cares, whether it's considered necessary or not necessary care. Pediatrics, people will keep their kids away from their annual checkups at increasing rates with increasing amounts of copay. They stay away from care if they have copays, if they have, quote, skin in the game. It doesn't make them better shoppers. It makes them non-shoppers. Half of adults in the United States in this Kaiser survey put off care because of costs. Some say their conditions got worse. So 51% of people across the board surveyed are putting off care, relying on home remedies, skipping dental care, postponing needed care, skipping a recommended test or treatment, problems with mental health care because of costs. Half of the population. People skip drug doses with modest co-payments. Here we have data. Almost 17% of people in the U.S. report skipping drug doses, less than half that number in Canada. And the Canadian system does not uniformly cover drugs. It's not part of, in general, of the different provincial systems in Canada, but they pay less because they negotiate with the drug companies. And look where all the other comparably wealthy countries fall on this graph. This is a scary paper. Health Affairs from March of 2019. It turns out that when women were switched into high deductible health plans, women with a breast cancer diagnosis, they experienced delays in breast cancer diagnostic testing, delays in early stage diagnosis, delays in chemotherapy initiation when they got switched into a high deductible plan. So this idea of skin in the game, making you a better shopper, here it could be lethal. Lethal. Okay, finally, this is maybe the biggest of all. We can't afford it. Say the naysayers. How are you going to pay for it? Almost always the first question when you bring up improved Medicare for all. Here's my first place answer is, you know what? We're already paying for it. We're talking about where the dollars are going to come from. We're talking about our expenditures, roughly $3.5 trillion a year. It turns out that the government is already paying for about 60% of our total health spending, Medicare, Medicaid, CHIP, et cetera, the military, about 60%. So what we're talking about is, with improved Medicare for all, is finding out where to get the rest of that 40%. Where are those dollars going to come from? If they're going to come from something to do with government, if they're not going to come from out of your pocket with your private health insurance. And it's going to be less than that 40% because the economic analyses, the serious analyses that have been done on the costs of Medicare for all come up with uniform findings. Here's an important study from UMass Amherst's Political Economy Research Institute. An economic analysis of Medicare for all, improved Medicare for all, found that, sure, they estimate, yes, utilization would go up if people don't have to pay out of pocket and you cover everybody by, they estimate 12%, but the cost savings would be over 19%. So on balance, we would achieve a cost savings, total expenditures of almost 10%. We would spend almost 10% less than we're spending now to cover everybody under improved Medicare for all. A second paper, which came to similar conclusions, found that a simplified billing system would come up with savings of nearly 15%. And then most recently, this was in the news recently, a Lancet article, the Lancet from the UK, a group of Yale researchers made this calculation that under the Improved Medicare for All Act, we would reduce our national health care spending by 13%, they estimate. And by the way, it would save over 68,000 lives. Now, so we're getting estimates in that 10 to 15% range, but they're pretty consistent. And in fact, an economic review article of these analyses found a high degree of analytic consensus for the fiscal feasibility of the single payer approach, okay? We'd save money. We just have to figure out where that extra chunk comes from. And let me say, and so it's no surprise that last year, 219 economists signed on to this call for Medicare for all, improved Medicare for all, because single payer, they said, would provide good quality care for all U.S. residents as a basic right while significantly reducing overall health care spending. It would reduce spending. Now, people have argued and peppered Bernie Sanders with this. How are you going to pay for it? It's been on his website all along, and people can go there. We don't have time to go into it. But Bernie Sanders had a detailed plan, a set of proposals for how he would pay for it, as does Elizabeth Warren. She posted it on Medium, how to pay for Medicare for all. We're running out of time, so I can't go into it, but you can find these data. They're out there. I want to just mention the Affordable Care Act, and then I see we're running short of time. I'll just say that the Affordable Care Act was the Obama administration's attempt to provide some insurance for more people while basically leaving the healthcare private health insurance landscape intact, but more regulated. This is what it looked like to a cartoonist. Okay, maybe they didn't consider single payer, but better than the Republicans. The simple GOP plan: get sick, die penniless. I'm going to skip to the end here because I'd rather take questions. But the Medicaid expansion that was part of the Affordable Care Act, it's left up to the states, and only 37 states have adopted it. It has driven down the number of uninsured people. I will skip to the end. There are definitely improvements in health outcomes that have been demonstrated from the Affordable Care Act, including early stage cancer diagnosis in the states that expanded Medicaid under the Affordable Care Act. It's estimated that almost 20,000 lives have been saved by expanding Medicaid under the Affordable Care Act, but it makes underinsurance the norm. That if you buy an insurance plan on the Affordable Care Act, you're on the hook for a large share of your medical expenses, sadly. And medical bankruptcies haven't changed with the Affordable Care Act. I'll just skip to this. Our president promised us a beautiful plan that would cover, you would be beautifully covered. He said, maybe this is what he meant when he said beautifully covered. Basically, they've spent their energies attacking the Affordable Care Act because it has Obama's fingerprints on it. One of the big things they've done is they've allowed the states to put a work requirement on Medicaid, which means it's not a human right, that you have to work to deserve it. in the view of the Trump administration, and because of that, because they don't consider health care to be a basic human right, that when Arkansas implemented work requirement in their Medicaid, when they applied the Medicaid work rule, 18,000 people were kicked off of their Medicaid program. And Kaiser looked into that, and it turned out that the large majority of those people just didn't understand what they had to do. It got more complicated. Monthly reporting seemed confusing and burdensome, hard to manage, so they lost their coverage because of this work requirement. So if you really want to know what Trump wants, look at his budget for 2021. He proposes cutting $1 trillion to Medicaid and the Affordable Care Act, meaning that 20 million people would lose coverage if Trump's budgets were enacted. I'll stop there and just leave us with this image of National Nurses United demonstrating for improved Medicare for all. National Nurses United, one of the most effective organizations in the country, pushing for what we need. So let's stop there. I'm sorry I ran over a little with our technical problems.
Great, Alan. And for those of you in the chat, I just want to let you know that we have been recording the meeting, and we will be distributing the recording via email following, so probably in the next few days. Thank you.
All right, so let's just go through some of the questions in the chat box, and then if anyone has any other questions afterwards, feel free to ask them. So Dr. Meyers, Candy had an excellent question. She said, what's the plan for overcoming the educational disconnect?
Well, that is a critical question. You know, on the one hand, we see that a majority of people are already behind the idea, but don't get the details. We have to do more of what we're doing right now. We have to have we have to get in there by every means possible. We have to write letters to the editor. We have to talk to our congressional representatives. We have to be well-versed in the basics ourselves. I encourage and urge people to visit the Physicians for National Health Program website. National Nurses United has excellent stuff up there. Get familiar and start talking about it, because, you know, there's a feeling of many people that a change this big is going to need a groundswell of support from the grassroots. We're not going to get anywhere without a mass movement. So we have to build a mass movement. And as I say, many of the unions are already there, but unions have been disempowered in the United States in recent history. But talk to whatever organization that you're a member of. You know, if you're a member of a religious congregation, if you're a member of a Rotary Club, it doesn't matter. This affects everybody. Talk to everybody you can, get informed, and join up with anyone who's working for it that's in your neighborhood, because, you know, getting together is the only way we get there. I don't know if that's specific enough, but that's really what I think.
Awesome. So then we also had another question that was, what are your thoughts on the argument against the government being in control in adopting a single payer system? And do you think there would be regional disparities as well?
Yeah, well, look at it this way. Would you rather have your elected representatives in our democracy? We like to think we're living in a democracy, in control, where you have some avenues to make change, or would you prefer it to be a private for-profit corporation where you have absolutely no say in anything that they do to you through the insurance product that you're purchasing from them? That's how I would frame it. At least if it's our government, we have some avenues of redress. You know, we can talk, we can work with our elected representatives, we can petition the government, we can organize, we can try to elect candidates who see it the same way that we do. We have none of those options if it's a private, especially a for-profit, but if it's a private enterprise that's in control, we don't have those options. That's how I feel about government having that role. As to whether there would be regional, that remains to be worked out. I would hope that people would get uniformly high-quality care or access to high-quality care no matter where they lived in the country. Of course, there's variations in what's available to people in different parts of the country, but that would be much easier to manage if we had a uniform national program in place that was paying for it. There's enormous power with that, including power to negotiate down prices with big pharma, if everybody in the country were hooked up with the same program.
Thank you, Dr. Meyers. And what do you say to those who support Medicare for All who want it? As a supporter of single payer, I've struggled to convince others.
Yeah, it's a very good question. You know, it sounds appealing. My bottom line answer is we would not realize any of the savings by maintaining this complexity, because what it means, Medicare for All who wants it, means that you would add one more option into the current landscape, and maybe some people could choose to go into that option instead of their current, say, employer-based health insurance plan. It's not even so clear, but the complexity would actually increase, not decrease. And the real risk, and many people have written about this, is that the private health insurers have ways of leveraging you off of their plans if you're too expensive. And so the fear is that a public option would start to collect all of the patients who are too expensive to be attractive to the private insurers, and they would wind up with a disproportionate share of very expensive patients with very high medical needs, whereas the private insurers would be able to siphon off the healthy people with minimal needs. That's the basic, and we would not realize any of the savings from overhauling this complexity that we don't need, that adds nothing but expense and headaches. So that would be my answer. I don't think the public option is going to get us there. I think it's a sidebar, and we need to keep focusing on the big picture.
Thank you. And if a single payer system is established in the United States and salaries for physicians drop, do you envision their loans decreasing or medical school tuition expenses dropping?
Yeah, it's a great question. And there's a lot of unknowns here, and I will freely admit that. But remember, physicians would not have to be, if they're in a private practice, they would no longer be paying out of their practice income for the administrative staff to deal with all of these different insurance companies and fighting with insurance companies. They would have predictable revenue because they would know everybody would be being paid on a uniform scale. So the costs would go down. Also, costs for hospitals would drop because they don't have to have this administrative superstructure to deal with the multiplicity of insurers. So I think it's important to keep that in view of what the simplification would get us. And it would mean less spending for
Oh, looks like Alan froze a little bit.
It's okay now.
Let's give a moment. It might he might be able to refresh and come back with us.
Let me just email him quickly to make sure he's aware.
And folks, please feel free to continue to chat in questions as we're waiting. There's a really great, vibrant list here of questions, but also resources. It looks like we have a great audience of folks who are connected to MassCare, which is our Medicare for All advocating organization right here in Massachusetts, in Boston, as well as folks associated with the nurses movement, of course, with PNHP, Healthcare Now. The good news is we have a lot of incredible resources and allies in this work. So please keep chatting your questions, and hopefully we'll be able to have Alan rejoin us.
I'm wondering in the meantime too, I'm just emailing Alan now if we could continue discussion around overcoming that educational disconnect that Alan was talking about, and if other folks, oh, here he is, never mind, great. Hi, Alan, we lost you there for a second. Can you hear us?
You're on.
Sorry.
Here we go. We've
I
got
don't know
you.
why I got dropped, but I just got dropped.
Welcome back.
I'm so
Cara,
sorry.
do you want to pose the next question as we were just...
Yeah, no worries. So Stevie and Bruce actually asked two really good questions that I think we can combine together. So they wanted to know, how do you see dental benefits and coverage incorporated into improved Medicare for All? And also, how would single payer help rebuild and coordinate the public health infrastructure that we see failing us so badly right now?
Oh, those are very good questions. Dental is included in the House bill. I don't think the details of what that means have been worked out. For example, restorative dentistry, would that be covered? I think that remains to be seen. There's going to be a lot of the fine details that need to be worked out. But basic dentistry is part of the House bill, HR 1384. I'm sorry, the second part of your question was?
The second part was, how would single payer help rebuild and coordinate the public health infrastructure?
It's also a good question. You know, really single payer, I don't want to blow it up into something that it isn't. And I think single payer is only one step to where I think we need to be. For example, I mean, I was just about to, when I got my system kicked me off, I was about to make the point that I think it would be much more, talking about what physicians make and what medical schools, what it costs to go to medical school, I think a much more ideal situation would be to fund people to go to medical school, to pay their tuition and pay their living expenses and pay them a salary right on through the rest of their careers. That would be my, I mean, I personally speaking, as someone who is always a salaried physician, I don't see a problem with it. And I think in that way, we would attract more people to the practice of medicine who wanted to do it because they wanted to help people, they wanted to serve patients, and not because they wanted to have a lucrative profession. But that's not part of, I'm saying that's kind of my vision of what could be beyond single payer, improved Medicare for all. Mostly what improved single payer for all deals with is the financing. I think that opens up a lot of avenues for improving the public health infrastructure, but it isn't exactly the same. It would fall under the same department. It would fall under Health and Human Services, but it's kind of in its separate, it's saying, well, this is how we're going to take care of what it costs to take care of patients. We have to pay attention to our public health infrastructure. I couldn't agree more. That's clear for all to see. There are ways in which single payer would make it better, streamlined, no out-of-pocket costs for people when they get care. But public health, that's got to be addressed on its own terms.
Another question was, what are some concrete actions we can take to help the Medicare for All movement?
Well, again, you can contact your representatives in Congress. I mean, it's a little thing, but we like to think of ourselves as a democracy, and tell them how you feel and point out that there are bills in the House and in the Senate. And again, there's HR 1384, S1129, the Jayapal bill in the House, the Sanders bill in the Senate, that you would like their support. You would like their enthusiastic support. If they're not a co-sponsor, you would like them to be a co-sponsor. That's pretty concrete. It's a little thing. The other concrete things, you know, I would say support the organizations that are pushing in this direction. And the ones, as I say, National Nurses United, I have all the respect in the world for that organization and what they're doing. They're probably the most prominent organized voice in the country. I would go to their website and say, how can I help you, nurses? It's a nursing union. Go to PNHP, download some of the materials. You could organize a group, as I say, within your own community. I can't tell you because I don't know you guys and I don't know what your options are for organizing, but you know, people have connections. All of us have connections, whether it's through a faith community or a community organization or a PTA. You can talk to other people about it. You can organize with other people. So concretely, I would point out the organizations, especially National Nurses United and PNHP, see what they've got to offer. Look to your own congressional representatives, look to your own organizations. We have to do this from the grassroots up. There's no other way it's going to happen.
Thank you so much for that. And actually, we also got another good question here. If Medicare for All was adopted, do you think it should be phased in? And how do you think we could avoid a shock to the healthcare system?
Yeah, it's another good question. First of all, there's a 2-year phase-in on the House bill. The Senate bill has a 4-year phase-in. And a lot of those details would be worked out. And yes, there would be some, I think there would, it's the funding part of it would be huge, but with a sufficient amount of warm up in the transition, and again, a 2-year transition period, it's not that big a stretch. Right now you have private physicians' offices getting reimbursed by Medicare and Medicaid. So they'd be reimbursed similarly from the government, but from now a unified structure. And again, whether that be at the state level, or the national level, or a regional level remains to be worked out. But I don't think that the compensation part is going to be such a big deal. That really operates on the back end in the office and out of the in the shadows, kind of. We don't see it operating every day. What we do see operating wouldn't really be that different. You'd call your clinician of choice, you'd make an appointment. You'd get an appointment, you'd go there, and you wouldn't have to worry about the payment. It would be taken care of. That part would be so much easier. It would be such a colossal relief for just about everybody in the country that, I don't think it's going to be that challenging, actually. Once we've made the legislative commitment, I think the rest of it will fall into place.
There was also some debate about the capacity of government to be able to handle a program like this. What do you think about that? Do you think our government would be able to handle administrating this program? I
do. And as I say, the government right now is handling 60% of the total expenditures, and that's with a colossally fragmented system. We're talking about spending less in total, but through a much more simplified administrative structure. I have no doubt that the government will be able to, because they're doing it now with all of this complexity. Make it simple, and it's easier for everybody, and that goes for the administrators in the government as well as patients like us. It would be easier for everybody, not more complicated. That's the whole point. So I don't think that's an issue either. I think it's going to be easier to, I know it's going to be easier to do.
We also had some comments about racisms in health from Paula. Given healthcare disparities, would universal coverage address racism in healthcare? How might universal healthcare rectify racial injustices in health?
Boy, that's a deep question. Let me say that if everybody has the same coverage, then there would be no financial reason to discriminate against people. For example, right now, if you're poor and you're in the right categories, you can get Medicaid coverage. Well, Medicaid pays less. And so there is an economic disincentive to some clinicians that is in a way that's linked to race, because poverty is linked to race. I mean, there's poor white people, but disproportionately minorities are afflicted with poverty. And so if they're, if they're on Medicaid and Medicaid is reimbursing less, that's going to go along with that. That's erased. So from the point that we have universal single-payer health coverage, then the reimbursement would be the same. That wouldn't address the racism that might exist if, just because of the color of your skin or the language you're speaking, someone doesn't want to treat you. But it wouldn't be based on the economics of it. That part would go away. So I can't tell you that automatically, I wish it were true that, everybody in the healthcare world would not be racist if they were. That's not going to happen just because of the payment scale. I don't want to oversell it. but no longer would there be an economic reason to discriminate against poor people. Let's put it that way.
Awesome. We had another question. Would improved Medicare for all cause a huge increase in the number of people who abused the system of people going to the doctors? If there was no skin in the game, would everyone go to the doctors for anything which would further tax the system?
I'm glad you asked that question because, again, we have data. The studies were done in Canada, and what they showed was that when Canada did its transition, it didn't happen. There was increased demand from people who hadn't gotten any care, and there was somewhat reduced care from people who already had private insurance. But in general, the system was not overwhelmed. And again, the UMass analysis said there would be an increase in utilization of about 12%, was their estimate, but costs would drop overall because of the simplified financing. So the real world experience that we have, and I can refer, it's not one of the references I put up there, but there is a paper that asked this exact question, drawing on the Canadian experience, and it didn't happen in Canada. So I have no reason to think that it would happen here either.
There was also a question about holding community viewings. Somebody recommended the documentary Fix It, and they wanted to know what you would think about that. I
think Fix It is I'm glad somebody said that, because, I actually have the disc. It's such a good video, and if people haven't seen it, this was put together by business advocates for single payer, because there are people in the business world who know that this is the best idea and have put real dollars behind it. And one of those people was responsible for the production of that video. So I highly recommend people watch it because it's from a business person's point of view, which is different than my perspective, but it's a valuable perspective. So definitely, I think maybe you can stream it even if you don't have other access. Fix It is the name of the film. Highly recommended.
All right, well, we're going to wrap up now. Dr. Meyers, again, thank you so much. This was a fantastic talk, informative. It has many of our brains sort of churning of how to address, one, the educational disconnect and so much more. So we truly appreciate the time that you've given to learn along with us and share your information. Thank you to every single one of you who came this evening. Please, please, please stay connected with Here for Justice. We have so many amazing students who are learning about public health and health equity, who are eager to connect with you all and push forward many campaigns around not just Medicare for all, but addressing the racial inequities that we see in our systems. So I will chat once more our social media profiles. Again, you will get the slides as well as this recording. I would say follow our profiles if we don't have your email information as the best way to get the recording to this as well as the slides. So again, thank you, Dr. Meyers, and thank you all.
Thank you for the invitation. I want to thank our other co-sponsor also, South Shore Action, and thanks to everybody who tuned in. Thank you for inviting me. Let's push forward. Grassroots movement is the only way to get there.
Thank you so much, Alan. And for folks who don't have my email address on file outside of Here for Justice, I put it in the chat room, natalia.martins@simmons.edu, for folks who want to reach out and get the slides and recording.
Bye.
All right. Have a nice night, everyone.
Good night, all.